I'm Claudia Sommer, a professor of neurology at the University Hospital of Würzburg in Germany. I have an interest in neuromuscular disorders and pain. I have worked on these subjects throughout my professional life, and the immune neuropathies that we're talking about today, like CIDP, are in the center of my clinical and research interest.
And I'm Alex Seluzhytsky. I'm global medical lead for our Riliprubart program in CIDP. In terms of my background, after a short clinical practice as an internist, internal medicine physician, I joined Sanofi and worked in different therapeutic areas, including neurology, oncology, and cardiovascular disease, leading our various medical programs.
The name is chronic inflammatory demyelinating polyradiculoneuropathy. That already says a lot. It can start rather acutely, but then it usually remains chronic. We know that inflammation plays a role, inflammation of the peripheral nerves and the nerve roots. That's where the radiculoneuropathy comes in. And part of the pathophysiology is that these peripheral nerves demyelinate, lose their myelin sheath. Everybody can get it, from children to very aged persons. There is an increased incidence in the elderly that probably has to do with processes in the immune system that change as we age. And also men get it a little more often than women, which distinguishes this disease from many other autoimmune diseases that are more frequent in women. It is a clinical diagnosis. It has been written up many times, but most recently in the 2021 version of the guideline on CIDP diagnosis on treatment, published by the EAN and PNS. And there are clinical criteria that have to be fulfilled, including where the weakness has to be in proximal and distal limbs and mostly symmetric, and where the sensory disturbances, the sensory deficits have to be, and that the development is for at least 8 weeks. And in addition, we have criteria on electrophysiology, so nerve conduction studies that have to show the demyelination, which is not trivial because you have to do it well and you have to measure lots of nerves. And then we have some additional supportive criteria that we can use if otherwise the criteria are not fulfilled. And these include nerve imaging by ultrasound or MRI, or the examination of the cerebrospinal fluid, and a few other things. So it's a complex diagnostic process, and we do not have that one biomarker that tells us this is it. So if a patient develops weakness in legs and arms, and this is progressive, so with time it gets worse and worse, maybe over 2 months, 3 months, or even longer, with or without sensory symptoms, which means loss of sensation or even pain. So with that, I would think of CIDP. There are, of course, other diagnoses to consider, to exclude, but that would be a quite typical picture. Well, when the diagnosis is made and they are properly examined and staged, we have standard therapies, which we have had for quite a long time, so nothing has changed for many years. And the standard therapies are corticosteroids. This is what we've had for the longest, just broadly suppressing the immune system. We have immunoglobulins that can be given intravenously or subcutaneously in the last years. And the third option is plasmapheresis, plasma exchange, which is not done so often because it's quite a cumbersome process, but it also works in some patients. So these are the three pillars of treatment we have and we've had for quite a while. Riliprubart is a new compound with a new mechanism of action. It blocks complement. The complement system or the complement cascade is part of our defense against pathogens. It's quite complicated, and you can block it at different stages. So Riliprubart blocks it at quite an early stage. There are also different pathways within this cascade. So Riliprubart blocks the classical pathway, and there are two other pathways that remain unblocked, which is important because the organism, even when treated with this drug, still needs to be able to defend itself against pathogens. Studying the pathophysiology of CIDP has revealed that complement activation plays an important role. Complement can attack both the myelin and the axons. If complement binding occurs to the inflammatory cells, a process is started that involves the membrane attack complex, and that's a very powerful process that really destroys whatever cell or structure it gets hold of. Again, all physiologically meant to protect us from pathogens, but if it is directed against the self with the help of autoantibodies or antibodies directed against the self, it can be detrimental to, for example, a peripheral nerve. So blocking this complement pathway in an early phase seems to be quite an efficient way to stop this inflammatory process in CIDP. When there is a new substance that is developed into a drug, there are the clinical trials, phase 1, phase 2, phase 3, and a phase 2 trial with Riliprubart has been completed. At this meeting was the first time when we are seeing the data of this completed phase 2 trial. It's been quite a long trial, including its extension period. It has lasted for 1.5 years. So we know quite a lot about these participants. It was an open trial, so every participant got the drug, and the participants were grouped into 3 groups. So patients who were on standard of care treatment, patients who had been or were on standard of care treatment but didn't respond properly, they were called refractory to the treatment, and then treatment naive patients who were newly diagnosed and had no treatment yet. Interestingly, all these 3 groups benefited quite considerably. So you wouldn't be surprised that the treatment naive patients benefit, that they get better on the drug. But even those that were properly treated with standard of care treatment, a considerable proportion of them got better on the experimental drug. And even the so-called refractory patients, considerable portion of those got better. Many of the patients stayed in the extension phase, which also shows that they were quite happy with taking part in this trial. The good results were confirmed over time. So this was really quite a positive outcome. Next steps are the big phase 3 trials where the drug has to be compared to placebo or a comparator. And 2 of these phase 3 trials are ongoing. They are still including participants. So every physician who has patients with CIDP can include these patients into the trial. And I think physicians would have quite good arguments to maybe convince some of their patients to take part into the trial, because the results of the phase 2 trial were so encouraging And because there are many CIDP patients out there who are on standard of care treatment, but who still have residual deficits and who might even get better. I just would like to say that after many years now, this is the first time in the treatment of CIDP that new compounds are arising, and complement inhibition is one path, one very promising path, and there are also other mechanisms of action out there. So it's a very exciting time for all physicians treating CIDP.
But despite the current treatments available for people living with CIDP, there is still a huge unmet medical need, and there is significant burden remaining for these people. Up to a third of patients could be refractory to available therapies. Among those who do respond, response is always incomplete and often temporary, and there is still significant residual disability for many of people with CIDP. And we are very excited about the data for Riliprubart presented at this conference, because it may offer an additional option for these patients in the future. And Sanofi is committed to advancing therapies for people with CIDP through our ongoing phase 3 trials.